starting right now with Dr. Perry Fleisher, who is the one of the cardiologists at ACMC. Haven't seen you for a while, Perry.
Yeah, it's been a few months now.
Yeah. So how's it been going?
It's been busy.
Has it?
It's been very busy, and we've been growing as time has gone by. Because when I first came out here to join you, I was the sole Cleveland Clinic Cardiologist coming out to Ashtabula. We've now grown to 5 cardiologists.
Really?
Of course, you've met Dr. Stevens.
Very well, yeah, good.
He's been out here from time. We have Dr. Rosario joined us last year.
I don't think he's been on.
She came in and joined us in October. No, and she hasn't been out here.
Okay.
Dr. Rosario is a specialist in congestive heart failure.
Okay.
And we just had Dr. Greg Wood join us. Greg is a interventional cardiologist like myself and Dr. Stevens, and actually I've known Greg for quite some time. I used to work with him when I was working down in Stark County.
Okay.
So I've known Greg for quite some time, so he's quite a pleasure to have him on board. And starting in the middle of December, we have Dr. Dan joining us. Dr. Dan is currently in Michigan. He's a clinical cardiologist, and so he'll start on December 15th.
Wow. Now, will all these doctors be practicing out of ACMC?
All of us will practice primarily out of ACMC. We do spend time at the main campus in Cleveland on a regular basis, but we spend more than 90% of our time at ACMC.
I had a guy ask me here a few weeks ago, like in your case, Doc, do you do the actual open heart surgery, or
no?
No. How's that work?
Those patients needing open heart surgery are referred to institutions that have open heart surgery programs, and open heart surgery is a specialty that requires volume to maintain a good outcome. And so you don't want to be doing open heart surgery in places where you're only doing 50 or 60 cases a year. You really want that done in an institution where multiple hundreds of cases are done. So we refer our patients for open heart surgery to whatever institution they would prefer to go to. Obviously, a lot of them go to the Cleveland Clinic in Cleveland, and that's something we discuss in detail with the patients when the indication is present.
Okay, very good. Now, this is good. I mean, I'm kind of amazed right now because of 5 cardiologists. Because so often when a hospital only has 1, and even 2, it's hard to get in.
It is. And we've had, lately, this past year, our access time has been abysmally long.
What do you mean?
Meaning that if you called for a new appointment, some of the new appointments were being booked 6, 7, 8 weeks out from the time, and that's just not an acceptable situation. And it wasn't because of desire to delay things, but rather we just had completely full schedules. So we feel that...
what about the patient, though, that really needs to get in?
We've always handled emergencies on an as-needed basis.
Okay.
So if I can get a call, especially from one of my physician colleagues, usually calling to tell me they have a patient that they felt was unstable or needed more acute attention, we would find a way to find the time to see them. We can book them over extra hours at the end of the day, or whatever needed to be done.
Sure.
Obviously, but we felt that patients certainly should not have to wait that period of time to get an appointment. So for the Cleveland Clinic's community centers for cardiology, our benchmark is less than 14 days, and right now we should be considerably less than that.
Wow.
Many patients over the past 2-3 weeks since Dr. Wood joined us, we've been able to offer them appointments same day, next day.
Oh, wow.
Wow.
So I don't want to promise that that's going to be the case forever. It would be nice, but the reality is usually within a week's time is what we're shooting.
And the circumstances under,
Obviously.
Yeah.
I have a question, if you
Sure.
don't mind. Now, if you referred a patient to Cleveland Clinic for an open heart surgery or for like a valve replacement or something along those lines, if the patient needed to do follow-up, some of them have to go back to Cleveland Clinic, or will you actually see them right at ACMC for follow-up?
No, we see them in follow-up at ACMC.
Oh, wonderful.
That's a good question.
If the surgeon himself feels that the patient needs to have a surgical follow-up, something for wound care or some special circumstance, then yes, some of them are asked to return to the main campus. And I believe that they like to see their patients about 2 weeks out. So many of them are asked to return to the main campus for a single 2-week follow-up. But thereafter, all of their follow-up can be with us.
With you. That's wonderful.
That is excellent.
Especially for a lot of the older folks in the area, the drive time.
I don't remember if I asked you this or not, but I had a doctor out of Cleveland Clinic. I want to say his name was Sharkey or Starkey. Can't remember now. So many years
It's
ago.
not ringing a bell, but go ahead.
And he was a he wrote books on heart, and excellent doctor. I'll have to find the name and see if you know. I'm sure you probably know who he is. I just have the wrong name. But yeah, he was a very good doctor out of Cleveland Clinic. He really set my path straight there. I know she got a couple little things here for me.
Yeah, I've got a lot of goodies here. And as I get into this, I don't want to fail to mention that in addition to the 5 full-time cardiologists that we have Dr. Conj, who comes out to our office from main campus once a month. Dr. Conj is an expert in heart rhythm abnormalities. He's what we call an electrophysiologist. So he holds office hours and does procedures, and actually we'll see some inpatients about once a month on a consultative basis for us for special rhythm abnormality problems.
Yeah.
And I mentioned this.
That seems to be kind of common.
It is very, very common.
Yeah.
And while the rhythm abnormality problems are things that we deal with on a day-to-day basis in our practice, there are some more advanced or complex problems that require the extra specialty that Dr. Conj brings to bear. So he's a welcome addition.
Would that rhythm thing include like palpitations and?
That's usually on the simpler end of it. Yes, we deal with palpitations that some of which are due to rhythm abnormalities.
Yeah.
Sometimes it's quite frustrating because they can be intermittent and not immediately available to us when they come in. It's a rare instance when the patient has these things that happen, perhaps for 30 seconds once or twice a month, and it's extremely unusual for it to occur when they're seeing us in the office. It would be nice to hook them up to the EKG machine and have them perform for us, but it doesn't always work that way.
My wife had that problem, and she went through your hospital, and they hooked her. She had the echo, she had the EKG, and she also had the monitor.
The monitor. We have a monitor. It's actually that monitor. The Halter Monitor is a recording device. Back in the old days, it actually had a tape in it. Had a magnetic tape like a cassette, and it records the EKG continuously for the time that you wear it, usually 24, sometimes 48 hours that we do that. And then we can rapidly read that tape through a computer that speeds up the process and look for irregularities in the rhythm. It's a very, very good tool for finding those things. But again, it has to, the rhythm abnormality has to happen, the symptom has to happen during that 24 hours, and some of them just don't happen during that period of time. We do have a longer term monitor, one of them that we can wear for 30 days. Patients can take it off and put it back on themselves. And this doesn't so much as record the EKG, but actually transmits it over a wireless system to a monitoring center. And that's another way of looking for these transient rhythm abnormalities. And then these devices that I have in front of me here, which I'll hold up for you in a moment, are the ultimate, I think, in monitoring. And I'm going to show you the old one first because I think I brought this unit here once before when we talked about pacemakers. And let's see, can we, I don't know if everybody can see that. Yeah.
So you can zoom in on that.
It is This is an implanted monitor. It goes under the skin with a very minor surgery done with local anesthetic, and it continuously monitors the heart.
Look how
These
small
were
that is.
these, as you can see, it's about the size of a thumb drive that you use on
right.
your USB drive that you'd use on your computer. Used to say it's about the size and shape of a pack of gum, but they don't make packs of gum this shape anymore. So, I'll turn it sideways. It's really quite thin. This has been around, believe it or not, for well over 20 years, and there are obviously some very specific applications for this device. It has a battery in it that lasts for about 3 years, and when the battery is depleted, we remove it and discard it.
Where does that go, in your chest?
Usually goes under the skin on the chest, right alongside the breastbone, and this can be interrogated by a device. There's a paddle, if you will, that goes over it that the patient holds, and they press a button on it while holding it over the place on the chest. So if it's placed about here in the middle of the chest, you would take your transmitter unit, hold it over it, press the button, and it would record everything that the device has seen, and it would then upload it. It's hooked up to your telephone, and it's uploaded to our device clinic center, which is at main campus for us, and converted into a printed report, which is then put into the medical record as a part of the computer printout. This is 20-year-old technology, and it was really a marvel when it came out, and it's still used in many situations. But recently, over the past year, this has been supplanted by this little fellow.
Wow.
You're kidding.
As you can see, is hopefully, yeah, I'll put these side by side for a moment. You can see the size has been dramatically reduced, and much thinner. So this device,
much more comfortable too.
This device, yes, gets also implanted under the skin. However, this device comes to us in a cartridge that, once we've numbed up the skin, is actually just injected under the skin. It's not. We don't use surgery and stitches to put this in.
No kidding.
This is about a 30-second procedure to inject under the skin. Also, right alongside the breastbone.
Would that be considered? Now, get this clear. Would that be considered a pacemaker?
No.
No.
No. This is just a monitor.
Monitor.
This is all it does. Most people, when they have one of these in, unless they really look for it, you can't find them once they've been put in. Now, they don't move anywhere. They get locked under the skin right alongside the breastbone and the chest.
Wow.
And to compare these two, not only is this smaller, this has the same battery lifespan. This is 3 years long that the battery will last in this. And this one is even more useful because it will transmit its findings wirelessly to a base station that we give to the patient, and they usually have them put it next to their nightstand in their bedroom, because you have to be within about 10 feet of it for it to transmit. It's kind of similar to some people have cell phones with Bluetooth that'll transmit to their car while they're driving them, and it's a very similar situation. This has a type of transmitter in it that will communicate with the base station when you're within 10 feet, and it will then send the report to us wirelessly. So whereas this older one only reported when you asked it to, usually once a month, you send us a signal. This one will report to us anytime it has anything to say.
Now let me get this clear. Somebody would have to be monitored that long?
I personally took care of a patient many years ago who he came to me and he said he'd been driving his car and he felt well, and the next thing he knew, he was off the side of the road with the front of his car up against a tree, fortunately not injured and not a lot of damage, and didn't know how he got there. He passed out while he was driving. And we went through the usual monitors, the 24-hour, the 30-day, and we found nothing. He had a nice normal heart rhythm. He was an older gentleman. We thought perhaps he needed a pacemaker, but we couldn't prove it because his heart never went slow enough to need a pacemaker.
Huh.
And so at the time, this was many years ago, so this was the technology that we had. I put one of these in, and it went through its entire 3-year lifespan, and he never did have another symptom during that time, but he'd had it twice before. So we removed this when the battery expired, and wouldn't you know, about a month after that he passed out again, also while driving his car. Fortunately, also without an
Wow.
accident. So I put another one in, and about 2 years into that, so over a period of about 5 years, we finally captured an episode where his heart took off and was going 3 times its normal speed. It was over 200 beats per minute, and this had caused him to pass out. We made the diagnosis. We treated that specifically with a cardiac procedure, and we cured him of it, and he never had a problem again.
Is that right?
So in his case, it took 5 years to actually capture one of these
Wow.
events. So yes, there are some times when it may take that long to be able to capture. Now you might say, well, that's the exception, and it is. Most people that have rhythm abnormalities have them happen more frequently than that.
Mm-hmm.
But if you recall, we talked about atrial fibrillation on
Yeah.
one of our previous shows, and this is perhaps the most common abnormal heart rhythm that we see in adults, and as I had mentioned, then growing in frequency, and requires, in many people, protection from blood clots and stroke by being on anticoagulants. Well, we do have many people that we treat for the atrial fibrillation with either medications or procedures in which we hope and think that we've cured it. We've made it go away. Not a permanent cure, but perhaps suppressed it to the point that it's not occurring anymore, at least for a while. And many of those people would like to get off of their anticoagulants, their blood thinners.
Sure.
And we never know if that's safe, because if they go back into atrial fibrillation while they're off of it, and we don't know about it and they don't know about it, which is common, they may be at risk of having a stroke and getting a blood clot. And so one of the uses for this device is to take this and put this into a patient whose atrial fibrillation we think has been completely suppressed, and in selected patients, take them off of their anticoagulant and rely on this device to report to us if they go back into atrial fibrillation so that we can anticoagulate them. The old device would only tell us that when it was interrogated once a month. This one will tell us that as soon as the atrial fibrillation occurs. So,
Unbelievable.
Now, I'm going to ask
Standard
another
usage.
question.
Sure.
When you're using the newer device
Yes.
in a patient and it notifies you that there's something transpiring, is there an alert system? I mean, because I know those medical records can't be monitored all the time. Like if the heart peaked or slowed.
well, if this occurs, this will issue a report that will go to our device clinic at the main campus at Cleveland Clinic, which is monitored every day.
Oh, okay.
From there, it's uploaded into the computer system, and in the specific patients, I can program through the system, not actually through the device itself, but through our device clinic, to actually send me an email when that occurs. So I will actually be notified on my iPhone when one of my patients goes into atrial fibrillation.
You know,
That's amazing.
The technology that has changed just in the last 5 years to 3 years, it's unbelievable.
Mm-hmm.
I just can't believe it. This just amazes me here.
Yeah. So this is a very, very big improvement in the monitoring, in our ability to monitor people. Now, despite that, it's still a select group of people in whom we put this in.
Sure.
I think we've put in 3 of these so far since they came out. It's coming up on about a year since the FDA approved the device.
Okay.
So in this last year, in our clinic, we've put in about 3 of these.
Wow.
For instance, when we talk about technology, your hospital, her doctor, Dr. Chilcott, suggested that my wife have the sleep apnea test.
Yes.
And because of all these problems she was going through and the constant snoring that she's been keeping me up at night with. So she went and went to the sleep place and she couldn't fall asleep. So her doctor says, well, there is a change in the technology now. You can actually have it at home.
At home, that's right.
So she had that last night, and she goes, I slept, I fell asleep, and now they said it's not as accurate maybe as it would be under the clinic, but at any rate she had it done, so we'll have to wait for results. Now that also is something apparently that monitors what she was doing during the night while she was sleeping.
I send a lot of patients for sleep studies.
Yeah.
I'm certainly not an expert in that particular field of sleep medicine, but a lot of what happens in abnormalities in sleep carries over into what happens during the day in abnormalities in heart rhythm and heart function. And perhaps most commonly in patients with sleep apnea, if untreated and undiagnosed, can be a reason why we fail to control high blood pressure in certain people.
Really?
Patients with obstructive sleep apnea, untreated, may have refractory high blood pressure.
Okay. Okay.
So something I think about any time I have a patient who comes to me with high blood pressure that doesn't respond well to medication, is to consider that perhaps we have an undetected diagnosis of obstructive sleep apnea, and we'll do a sleep study on them. As far as the home studies go, obviously for patient preference, they're preference. They're much more comfortable
Right.
for the patients to sleep in their own bed. We tend to use the laboratory sleep studies. Having spoken with the people that run these studies, they're less comfortable doing the very elderly or those patients with severe heart conditions outside the laboratory. They would prefer to do those in the lab, but for younger and somewhat healthier patients, we do them quite a bit at home.
Do you? Yeah. I'm glad she had it done. Hi, you're on the air.
Yeah, I got a question for him.
Okay.
Hey, the 23rd, I had a triple bypass up there at the clinic by Dr. Mick.
Yes.
She's wonderful. She's
Yes, she
great.
is.
And I can still feel her hands on my heart. But where they grafted that artery at, they took it out of your leg.
Yes.
How? I still get pains in there. I mean, at like 1:30, 2 o'clock every night, every morning, I wake up and that leg is just killing me.
Oh, pain in the leg where they took the vein from.
Yeah. Is that ever going to go away, or sooner or later, or what?
I would expect that it does. I mean, they do a lot of open heart operations, and obviously there's some pain at the sites where the operation is done, including the leg where the vein comes from.
Yeah.
Everybody's kind of an individual. Some people will have pain at those sites a little bit longer than others, but if it's really been going on continuously.
During the day, it doesn't bother me, but boy, at night, at about 1:30 in the morning, I wake up and I mean, that pillow that they give you, for coughing and that, the heart pillow, I put that between my legs and that, trying to, to help it. And
How long has it been since the surgery?
July 23rd.
July 23rd, so it's been several months now. Has the
I'm
cardiologist
still
or
in
the
rehab
surgeon looked at the
and,
leg at all since then?
Huh?
Has the cardiologist or the surgeon looked at the leg since then?
That one up there in Cleveland, like you said, 2 weeks later, and they had to put. There was a couple stitches that didn't come out.
But not since?
No.
You might want to give them a call and tell them you're still having a problem and have them take a look at it. This is a bit unusual to have significant pain this far out, and somebody might want to take a look at it and make sure that there's not a problem.
Yeah, I was on the treadmill Monday at the rehab there, and I was going along pretty good, and then all of a sudden my legs started hurt. Man, I thought I was going to fall off that thing.
Yeah, that sounds like
hit the stop button.
that sounds like it ought to be checked.
All right.
Okay, Dennis. Thank you. Yeah, he had major surgery up at the clinic, and called me from the clinic, believe it or not, the Monday afterwards, and said, "I just want you to know I'm in the Cleveland Clinic. I had a heart attack over the weekend." Constant caller. All right. We are talking to Dr. Perry Fleisher. If you do have a question like that or anything else regarding cardiology, you're more than welcome to call in. He's here for another few minutes. Then he has to get on the highway because he has a busy schedule out there. So I didn't realize sleep apnea had so many different things that it could go wrong. If it
Turns out that disturbances of the sleep cycle can have fairly far-reaching effects beyond just waking up and feeling like you haven't had a good night's sleep.
Yeah.
But that sleep deprivation can can rub off into all sorts of cardiovascular problems, lung problems, or I shouldn't say lung so much as breathing problems, and problems with the blood count. All of these are interrelated, and this obstructive sleep apnea, something that we've known about for a very long time, but I think over the past 5 to 10 years, we've been astounded at the number of people that have significant amounts of sleep apnea that you wouldn't have expected to have sleep apnea. I used to think that this was a problem primarily of people who were extremely overweight, but we see this in individuals who are mildly overweight. We see it in some individuals who are normal body weights. So while we clearly think that there's a relationship to obesity, obstructive sleep apnea can be present in people for other reasons as well.
You know, I've always had high blood pressure, well, since my 30s, and they put you on different medicines and everything to control it. But you know what really, and I've said this before, what really helped it was losing 40 pounds. I couldn't believe the difference. It's perfect now.
Exercise and appropriate diet are keys to controlling blood pressure. Some people still need medication despite that, but the effectiveness of the medication and the amount of medication needed can be significantly altered by improved diet and exercise.
Back in May, I was having a pretty severe oral surgery I had to have, and I was a nervous wreck, and they have to take your blood pressure before it, obviously. And I go, it's going to be way up there. I'm sorry, it's going to be high. And she goes, guess what? It's 115/75. And I go, before this, I couldn't believe it.
You were a teenager.
Yes. It was like I couldn't believe it. But that, again, and other doctors have told me the same thing. It's weight loss is very, very important. You know. So, yeah. Now, Doc, you go back. Now, do you go back to the ACMC today?
Yes, I'm going to be there all day for the rest of the day.
Really?
With office hours later this morning, and then throughout the afternoon.
Okay. Okay. So if somebody wanted to get a hold of you, they just call the hospital and then. Yeah,
if they call the hospital's main number and tell them they need the cardiology, they'll transfer the call to our office. Our office number is 440-994-7622, and that will get us directly to the front desk.
Okay.
And you do not need a referral from your family doctor or any doctor. If you need to see the cardiologist, you can call and make an appointment. Sometimes having the primary doctor make the referral can speed up the process because they'll convey to us more medical information,
right,
and we can judge the urgency of the appointments. But now, as we've brought the extra doctors on board, the appointment schedule is starting to collapse back down to a reasonable time.
Sure.
There's still a few delays, but especially with the holidays coming up and the new doctors having just come on board, so we don't have immediate results, but it's shortened already, and we expect it to be down to very, very reasonable levels by the end of the year.
Excellent pattern of growth there at the hospital. I think it's tremendous. It really is tremendous.
We're very pleased. ACMC has been a great and strong host for us, and the services and support throughout the hospital are amazingly excellent, and so we're very proud and happy to be here and serve the community.
Very good. Always a pleasure talking to you.
My pleasure.
And come back and see us.
Absolutely.
Probably after the first year. So thanks, Perry. Appreciate it.
As I say, I'll try to bring some of the new doctors with me.
Okay, that'd be great. That'd be great. And I love the little demonstrations you bring here too. That just simply amazes.
That's amazing.
This is kind of the fun side of the practice.
Yeah, right.